And as far as the information that you had about her past psychiatric history, were there any indicators to you about manic episodes?
No. So I do recall in reviewing Julie's note prior to meeting with Lindsay, she filled out what we call a mood disorder questionnaire. It's like a screener somebody can do to assess history of mania and bipolar disorder. Lindsay it was a negative screen. So there's 3 questions. One question has 13 different symptoms. You have to score 7 out of 13 on question 1, but also in question 2, it asks about, are the symptoms happening at the same period of time? And then it asks about any functional impairment from the symptoms. So I recall the 3 symptoms she did endorse were not sleeping for that period of time with the Zoloft and not feeling tired, having racing thoughts, and trouble concentrating. None of the other symptoms did she endorse. They did occur at the same period of time. And I don't want to be inaccurate, so I can't remember what she said for functional impairment, but I believe it was minor impairment.
Okay, and so the fact that those were reported, but ultimately the full screen revealed negative for potential mania.
I did also consider, though, that the MDQ is less specific when it comes to bipolar 2 or bipolar not otherwise specified. There's bipolar 1 and bipolar 2. Both have mania symptoms as part of the diagnosis. Bipolar 1 is usually more severe in that it's typically, a patient might be hospitalized or it causes greater functional impairment. Bipolar 2, it's a shorter duration and typically less functional impairment.
And as far as determining diagnostically whether somebody might be presenting with bipolar disorder, is there a particular tool you use in your trade to try to assess that?
Typically something like the MDQ, and then you'll do more of an interview asking the patient about symptoms specifically and if they can ever recall a time where this may have happened in the past, because sometimes patients can't always remember when they're manic. So I was glad to actually have Patrick in the visit because he could sort of help us look at Lindsay's history more longitudinally, or at least since the time he knew her.
Okay. And as far as, so those tools that you're talking about, the MDQ and kind of screening tools that you use in practice, is there another tool that you use to assess whether a person meets particular criteria to be diagnosed with bipolar 1 or bipolar 2?
There are others, not ones that I've used.
So are you familiar with the DSM-5?
Oh, yes.
Okay, so while that's not the end-all be-all, it is a guide that tells you specific criteria, how to determine if episodes are manic or depressive, right, when it comes to bipolar.
Yes.
The difference between mania and hypomania.
Yes.
And so while you noted that there were some concerns reported, did what was reported to you rise to the level of diagnostic criteria for bipolar disorder?
Not at that time.
Okay. And when you explained this to them, your thoughts about her reactions to the medication and these reported prior symptoms, did Patrick and Lindsay seem receptive to your diagnosis?
I recall Patrick saying my wife is not bipolar. Lindsay looked at me. She did not say anything.
Okay. And was this the first time in this meeting on December 6th where you broached that issue or mentioned that?
Yes.
Did the conversation continue about symptoms and managing symptoms after that?
Yes.
were you able to get any more specific information from Patrick during that meeting? Not what he said particularly, but did you get additional specific information that kind of helped you assess whether you would change your diagnosis at that point?
No.
And were there still concerns in that particular meeting that the focus was trouble sleeping and the potential for addiction?
Yes.
As far as recommendations, did you talk about what's called tapering medication?
Yes.
And what were your recommendations regarding tapering?
So we talked about her concerns about the benzos. And we decided to come up with a plan to taper off of them.
And the last that had been reported to you via the MyChart messages was that she tried not taking it at all, ended up having horrible thoughts and felt deeply depressed, then took it and felt better. Right? So was it realistic to recommend completely stopping?
No.
So what is a taper? Like, why do you recommend tapers?
I recommend tapers to slowly get somebody off of something. And tapers can be useful because we might have somebody at a dose and they might say, oh, I'm too anxious to stop this, or I'm not ready to step down to another level, and we can kind of keep them on it longer. But at this point, since I had met her on November 29th and throughout the MyChart messages, there was multiple concerns voiced about benzodiazepines, and again in this visit. So I even did what's called a CWA assessment, which is something we use to determine if somebody's having actual withdrawal from benzodiazepines or alcohol. Again, I really wanted to show her I was assessing this and taking this seriously.
When you say CWA assessment, is that an acronym for something?
Yes, so it's
What are the letters, just for the record?
CIWA. CIWA.
Okay. And did you, when you do that assessment, does it give you some sort of score?
It does.
Ask the questions. And what was her score when you did that CIWA assessment?
1.
And what does that mean?
Minimal to no withdrawal. The only symptom she reported was anxiety. Her blood pressure was normal. Her pulse was normal. She had no nausea, no vomiting, no tremor, no tactile disturbances. People in withdrawal from benzos or alcohol will sometimes feel like there's bugs crawling or pins and needles. Auditory disturbances, so hearing things, seeing things. No sweats, no headache. She was oriented.
Okay. So with that, and knowing that she wasn't in withdrawals for Ativan, did you still recommend the taper and an alternative?
I did.
What was that?
I recommended Valium. The reason I recommended this is she had discussed rebound anxiety with me at our very first visit, feeling that rebound anxiety above her baseline once the benzo wears off. Valium has an extremely long half-life. It can, as in like 100 hours. It has a longer clinical duration of action. So I wanted to offset the chance that she would experience rebound anxiety. And it's often used when we're tapering somebody on shorter acting benzos. It's common practice to switch to longer acting benzos to do this.
And did you also have conversations about the other medications that had been at issue, the mirtazapine and the Seroquel?
Yes.
What did the defendant, what did Lindsay Clancy express to you as far as Seroquel? Did she want to continue with that?
No.
Did she explain why?
So she felt like when she took Remeron and Seroquel together, she felt weighed down and exhausted, but her mind was still awake and alert, and she just didn't seem to think there was a benefit to being on it.
And so did she express to you a desire to want to go back to trialing Prozac?
Both Lindsay and her husband expressed that that was their preference.
And was that something that you agreed with?
I did. I had shared with them that I had concern this could be bipolar. It's in my differential diagnosis, which is just all the typical diagnoses we might be considering. And that typically SSRIs are contraindicated, but she did have that history of being able to tolerate Prozac at 20 milligrams and do okay with no mania. So I thought that's what they were wanting to do, so we could do it.